Okay, good morning, everybody. Once again, a warm welcome to the second day of the 22nd Annual Academic Sessions. It's good to see everybody, or quite a few of you who have come very early in the morning, and we have a very interesting session indeed, something that's very important for a lot of us trainees and even for clinicians who continue their practice, because clinical science is something that that is essentially bread and butter for all of us. So who better to discuss this than a master in cardiology, Dr. Ruan Ekanayaka, Senior Consultant Cardiologist. He will be presenting the breakfast session on clinical science in heart disease. Over to you, sir. And I'm sorry, this session will be chaired by Dr. Ajanta Rajapaksa and Dr. Priyantha Kannangara, Consultant Cardiologist.
Shall I start?
Yes.
A very good morning to all of you. So we have this breakfast session on the physical science in clinical cardiology. Can I have the first slide, please? Now the subject is too vast to cover up in half an hour, but we will try to do our best and to do a quick job on it. Now we start with the general examination. And remember that the face and the hands are the most expressive of heart disease. Looking at the face, you look for the facial stigma of ischemic heart disease. The bilateral parotid enlargement due to heavy alcoholism, not mild alcoholism, heavy alcoholism is a risk factor for ischemic heart disease. Auricular hirsutism, the hairiness of the earlobe and the earlobe crease. What is this earlobe crease? You see it here. You see it here. Here you are. There is a marked crease on the earlobe. And that earlobe's crease is called Frank's sign. And it is an external manifestation of capillary dysfunction, and it may be a risk factor indicator of ischemic heart disease. Looking at the face, you look at the corneal arcus, you look at the centilloma under the eyelids, the central cyanosis and the malar flush. The malar flush you see in mitral stenosis with pulmonary hypertension. When there is venous congestion, only that you see this malar flush. And the venous pulsations and the carotid bruise in the neck. These are the facial clues to heart disease. Now, obstructive sleep apnea is a recently recognized important risk factor for ischemic heart disease. And when you look at the patient, you suspect that the patient might have obstructive sleep apnea. When you look at the patient's face and you see that the jaw, the lower jaw, is very small, is underdeveloped, and this is called micronatia. The lower jaw is underdeveloped, and this causes a compression of the structures in the pharynx, which may lead to obstructive sleep apnea. And when you open the mouth, you see that the pharynx is crowded. It is called the crowded pharynx because the pharynx is small and the lymphatic tissue around it are hypertrophied, and there is a tendency in these patients to develop obstructive sleep apnea. Looking at the mouth, look also for the gums, because chronic gingivitis and chronic periodontitis are risk factors for ischemic heart disease because they are a continuous inflammatory, chronic inflammatory state, and we know now that atherosclerosis starts as an endotheliolitis. It is an inflammation of the endothelium which causes the atherosclerosis process to start, and the chronic gingivitis and chronic periodontitis are known to be risk factors for ischemic heart disease for this very problem, factor. Looking at the ear, sometimes you see that the earlobe tends to pulsate, and this happens in tricuspid regurgitation. And when you look at the patient's ear, looking at all the other 5 features that I described, if you see that the earlobe is pulsating, remember that these expansile pulsations of the earlobe can be a manifestation of tricuspid regurgitation. Remember also that in the lower limbs you see the varicose veins, and the varicosities tend to be pulsating a little. This is a physical sign indicating that there might be significant tricuspid regurgitation. Marfan syndrome is the body habitus where the span of the upper limbs is greater than the height of the patient. You look, and that indicates that there is elongation of the limbs. The palate is high arched, and there is arachnodactyly. I'll give you the physical signs a little later. Here you see A thumb has, fist has been made with the thumb, and the thumb protrudes out because the thumb is long. You could grip the fist with 2 fingers, and the 2 fingers overlap because of the arachnodactyly. And there is upward dislocation of the lens, which is a manifestation of Marfan syndrome. Of course, all these patients may not have Marfan's. You may have a Marfanoid, where only partial expression of these physical signs might occur. Here is the arachnodactyly physical sign demonstrated again in the thumb and in the wrist grip maneuver manifesting that. Marfan syndrome is important because it is associated with mitral valve prolapse, aortic valve prolapse, aortic aneurysm, dissection of the aorta, ventricular ectopics, supraventricular tachycardias. And therefore, this is an important syndrome to recognize. Down syndrome and other congenital heart diseases are very often associated with heart disease. And you see a large tongue which can lead to obstructive sleep apneas. The large tongue, the brush-field spots which are brownish spots around the iris, and the simian crease, which is a single line on the palm, indicates that the patient has Down syndrome. Now, Down syndrome, trisomy 21, 40% have congenital heart disease, atrioventricular septal defects, VSDs, tetralogy of Fallot, persistent ductus arteriosus, and mitral regurgitation. Therefore, it is important to recognize this syndrome. You look at the hands and you see the digits, and we find that the digits are either fused together, which is called syndactyly, or there are extra digits, that is called polydactyly. And accessory digits in the Ellis Van Creveld syndrome indicates that there might be an underlying common atrium associated. Syndactyly, the fingers are fused. Usually, there is no special significance. But sometimes the digits are reduced in number, and there is hypoplasia of the digits in the famous Holt-Oram syndrome, which is associated with the ostium secundum AST. There is wrist bone abnormalities, there is absent thumb, and the long thumb which may be digitized, and all these you see the digits, the abnormalities in the hand illustrated there, the Holt-Oram syndrome. Homocystinuria. Now we know that homocystinemia is a risk factor for ischemic heart disease and accelerated atherosclerosis from the Framingham study. But initially the homocystinuria, which is a congenital disease, metabolic disease, was the one that indicated to us that homocysteine is important in atherosclerosis. Now these patients with homocystinuria have a lens which is dislocated downwards, and that is the only physical sign. Otherwise you see the physical signs on the biochemistry. And this is a prothrombotic state. Therefore, the systemic arterial thrombosis, venous thrombosis can occur, myocardial infarction and pulmonary embolism. And you see that all these are manifestations of a prothrombotic state. Homocystinuria and homocystinemia both are risk factors for ischemic heart disease. Macroglossia, when you look at the tongue, the large tongue, in primary amyloidosis. Now it is in primary amyloidosis that the heart is affected, because primary amyloidosis affects what is called the midline structures, whereas the secondary amyloidosis affecting the kidney etc. does not affect generally the heart. Now primary amyloidosis causes the large tongue, but we have other conditions causing a macroglossia, Hurler's syndrome, Down syndrome, and all of this can lead to obstructive sleep apneas. Then we have the hereditary hemorrhagic telangiectasia when you look at the tongue and when you look at the face. The telangiectasia spots, which you can see very in profuse, and this is important for cardiologists because it is associated with bilateral pulmonary arteriovenous fistulae. And when you have the pulmonary arterial fistulae, this is a cause of pulmonary hypertension, but also for clubbing, also for cyanosis, and for dyspnea of unexplained origin. Turner syndrome, webbing of the neck, white set nipples, important because it's association with coarctation of the aorta. Noonan's, webbing of the neck again associated with pulmonary valve disorder, ASTs and hypertrophic cardiomyopathies. And Noonan is the male version of Turner's. Autosomal dominant, which is not uncommon. And the life expectancy of these patients with these syndromes is normal and generally depends on how you have treated the cardiac status. A few more congenital abnormalities: myotonic muscular dystrophy, expressionless myopathic phases and bilateral cataracts, cardiac conduction defects. Heart blocks are very frequent in these patients. The Duchenne muscular dystrophies, you see the hypertrophy on the left side of the screen, hypertrophy of the calf muscle. It is a pseudo-hypertrophy, and it is associated with hypertrophic cardiomyopathies, hypertrophy, left ventricular wall anomalies in the post-basal area, and arrhythmias are also associated. Pes cavus, a feature of Friedreich's ataxia, associated with VSD. We have osteogenesis imperfecta. Sometimes it is a TARDA, osteogenesis imperfecta TARDA, associated with aortic regurgitation, and it is the light blue sclera which first indicates to you that we are dealing with osteogenesis imperfecta. The sclera is blue because of the thinning of the sclera, and so that the underlying retinoid is now manifested, choroid is now seen through that sclera, thin sclera, in a blue color. In patients who suffer from syncope, sarcoidosis may be important, causing heart blocks, and you have bilateral ptosis sometimes associated with this syndrome, with retinitis pigmentosa. So these are important things to remember. Williams syndrome, not uncommon. Supravalvular aortic stenosis is seen, and you see the broad forehead, the short nose, the full cheeks, the wide mouth, and the spread out teeth, all indicating that there might be underlying heart disease. The Argyll-Robertson pupil in features of neurosyphilis, now it is now of historical value, it is not there at all, we don't see this at all. The features of neurosyphilis, the tabes dorsalis, small irregular accommodation possible, reaction is possible, aortic regurgitation, if at all it is there for the multiple choice questions. Professor Carlo Fonseca used to teach the Argyll-Robertson pupil is ARP, which means accommodation reflex present. Turn it the other way, PRA, pupillary reflex absent. Professor Carlo Fonseca's mnemonic for remembering the Argyll-Robertson pupil. I come to the skin, and you look at the color of the skin. There is bronze pigmentation of the skin, a earthy brown pallor. Earthy brown, earth means in primary hemochromatosis associated with dilated cardiomyopathy, chronic renal failure causing earthy pallor, and Addison's disease. All these three are associated with heart disease, and the skin color indicates to you that one of these three conditions may be underlying. Acne on the face is important for cardiologists because of the risk of Staphylococcus endocarditis, now reported to be associated with acne. And in susceptible persons, antibiotic prophylaxis is recommended when there is a profusity of acne. Look at the conjunctiva. Of course, the pallor, the cyanosis, and the white central lesions of infective endocarditis. If there is conjunctivitis, look for arthritis, because this is associated with Reiter's syndrome. And Reiter's is associated with cardiac problems, pericarditis, atrioventricular blocks, and aortic regurgitation. Important. And therefore, conjunctivitis is a thing to look for. You look for jaundice. And are we as cardiologists interested in jaundice? Yes, we are. Because in chronic congestive cardiac failure, when the liver is chronically congested, mild jaundice is common. Microangiopathic anemia of prosthetic valve, especially in the aortic position, as the blood flows across this prosthetic aortic valve, a few of them get lysed and you get a hemolytic jaundice. The microangiopathic anemia of severe calcific aortic stenosis, again the same mechanism. And transient hemolysis following large pulmonary infarctions give rise to mild jaundice. And these four causes of mild jaundice, mild icterus, are important in cardiology because we suspect that there might be an underlying substrate there. Monckeberg's medial sclerosis is of no pathological clinical significance except that the locomotor brachialis sometimes that you see on the forearm, where the distended pulsations are seen in the vessels, extensive arterial thickening is there, but it does not seem to be associated with coronary lesions. It is gives rise to much anxiety to the patients, and therefore you know to reassure the patient. Remember that though we speak of ischemic heart disease as being atherogenic, it can be due to non-atherosclerotic pathology. For example, arteritis, the inflammation of the arteries. And you see this vasculitic rashes associated with polyarteritis nodosa, Takayasu and connective tissue disease, the vasculitis that you see on the skin indicates that having underlying arterial inflammation giving rise to ischemic heart disease. The Leopard syndrome associated with the lentiginosus. Sometimes we see 1 or 2 cases we have had when I was working at the institute. There are ECG changes, the ocular wide set eyes, the pulmonary stenosis, abnormal genitalia and retarded growth and dementia is there. And therefore it is called the Leopard syndrome. And lentiginosus are actually freckled brown macules, which you see mostly on the back. I have given the illustration. Associated with an AST, atrial myxoma, hypertrophic cardiomyopathy and valvular stenosis. Therefore, the skin manifestations are indicated even if you don't know the details of the associations to know that you need to investigate these patients. This is of course the famous hyperlipidemic features which you see on the lower eyelid, sometimes also on the upper eyelids, on the extensor tendons, therefore on the acronon, on the knees and in the Achilles tendon. These are the extensor tendons. It is there that the xanthomata occur. And in the younger people, around the arcus juvenalis. You can also see it on the palms, the palmar xanthomata, also called the xanthomata planum. Yellowish streaks are on the palmar creases and the finger creases. You can see it on the finger creases also. And common over the extensor tendons and the eyelids, as I said. We have an associated condition, the pseudoxanthoma elasticum. It is a yellowish waxy papules on the lax skin. It looks like a plucked chicken, like the chicken skin. And it is associated with a host of conditions, renal artery stenosis, systemic hypertension, coronary calcification, gastrointestinal bleeding and retinal hemorrhages, autosomal recessive condition, the pseudoxanthoma elasticum. Sometimes you see this in the neck. The cafe au lait spots are important. These are brownish. Cafe au lait means coffee with milk. Of course, the coffee with milk is in the white people. In our people, it is most like black coffee. The dark spots on the dark skin. And this is associated with neural crest tumors. Therefore, pheochromocytoma. Also with neurofibroma, neuroblastoma and the schwannomas. But we as cardiologists are interested because of the association with pheochromocytoma. But one cafe au lait spot is of no significance. Generally, you must have more than 5 to say that there is an associated neural crest tumor. The HIT syndrome is another thing that you look for when you look at the skin. HIT, the heparin-induced thrombocytopenia, that is what HIT stands for. Heparin-induced thrombocytopenia. Of course, now most of us use enoxaparin, but even with enoxaparin, the HIT syndrome is described, though less common than with unfractionated heparin. And here where I find is there is thrombocytopenia. Now, if there is thrombocytopenia, you must have bleeding. But in this condition, yes, you do have bleeding, but there is also paradoxical thrombosis because of the malfunction of these platelets. The platelets fall 30 to 60%, and when you look at the site of injection, of course you see this and you detect it when you do your blood counts, but when you look at the patient and you look at the site of injection and the site of a cannula, you see that there is a hemorrhage and a thrombus both at that site. And if you see this combination of hemorrhage and thrombosis at the site of injection of a cannula site, then the HIT syndrome is suspected on those clinical grounds. Cholesterol plaque embolization, the livido reticularis that you see in the lower limbs, sometimes also cardiac catheterization, you see this, and never again must you catheterize these patients unless you do an MRI assessment of the aortic arch, otherwise you can dislodge cholesterol emboli and cause a stroke. We come to the physical signs of interstitial endocarditis, which you can see in your general examination. In panel A, the Janeway lesion, reddish spot on the hypothena evidence. I will tell you some details again. The arrow points to the Janeway lesion. In B, you see the splinter hemorrhages under the nail. In C, you see the Osler's nodes on the pads of the fingers. And D, you see the rod spots on fundoscopy. It is a hemorrhage with a central white spot. And E, you see the petechial hemorrhages in the conjunctiva. So these 5 slides illustrate to you the physical signs that we can sometimes see in infective endocarditis of the left side. Remember, if the right-sided valves are involved, then the thromboembolic phenomenon will be manifested only in the lung. It is only when the immune complexes are involved that you find these generalized ones, and therefore it is common when the left-sided lesions are affected. Here we see the splinter hemorrhages. Our professor of medicine, Professor Dharmadasa, used to describe this as bits of dirt under the nail. That is how it looks for. And then you have the sublingual hemorrhages. Now, the splinter hemorrhages are not specific for endocarditis. Even people using vibratory equipment can have this, but it is indicates to us. Osler's nodes, relatively specific for infective endocarditis. Tender pea-sized raised areas in the pads of the fingers, toes, thenar and the hypothenar eminences. Now, what causes these lesions of endocarditis? Osler's nodes are due to immune complexes going and now all lesions in infective endocarditis due to immune complexes are painful. Janeway lesions, on the other hand, are septic emboli causing very small microabscesses, and for the most part they are painless. Retinal hemorrhages are due to rod spots, and splinter hemorrhages again microthrombi, therefore non-painful. It is the immune complex ones that are seen. Now, Osler's nodes are immune complex mediated. Therefore, whether the endocarditis is based on the right side of the heart or the left side of the heart, it is irrelevant because immune complexes can conquer anyway. And these will be painful. Whereas Janeway lesions, septic embolization, may not occur on pulmonary valve or tricuspid valve endocarditis. We look at the hands. Do we have any time? We have no time at all. So acrocyanosis, severe tips of the fingers, there is acrocyanosis. And there is shock, tight mitral stenosis, severe heart failure. Here is clubbing, and you see the physical signs of clubbing. There is a triangle in planal a triangular space there. Shamrock's window it is called. Classical clubbing in the middle panel, the drumstick and the thumb sign. Why do we talk about the thumb sign? Here is the Shamrock's window. 2 thumbs are kept together, and you see, because the angle is such between the nail and the nail fold, you see a triangular space. Now, in the thumb, it diverges out. Why do we describe the thumb? We describe the thumb because clubbing first occurs in the thumb. Therefore, if you find a patient and you want to find early clubbing, there is no point in looking at other fingers, you must look at the thumb. Even a congenital heart disease, after 6 weeks or so, that clubbing occurs, and it is mostly manifested in the thumb. It is not seen, and differential we will not, because I have only 7 minutes more, I will not talk anything about this. Now I will ask a few words on the external jugular vein. You look at the neck, and the external jugular vein is very easily seen. It is a non-pulsatile column. Why? Because it was non-pulsatile? Because it has valves. Now it indicates central venous pressure. Why is it distending if it has valves? When the valves become incompetent because of constant pressure. And therefore long-standing pressure in the intrathoracic or the right atrium will cause a distension of the external jugular vein. Is it a good manometer? Yes, in very chronic right atrial pressure elevations, yes, it is so. But we of course look at the internal jugular. Now sometimes you look at the neck and you find that the internal jugular you cannot see and the external jugular is seen. That is because of the patient is dehydrated and you have over-diuresed the patient. The internal jugular becomes non-manifest because of the volume depletion, whereas the external jugular vein is very easily seen. The internal jugular starts between the 2 heads of the sternocleidomastoid, and if the patient is flat, the JVP will go right out to the ear. When the patient is elevated at 45 degrees, it just comes to the top of the clavicle. And if the JVP is very high, then on the seated position we will see it in the neck. Therefore, a very moderately elevated JVP will be seen only when you are at 45 degrees, whereas you may miss it if you just check it and when the patient is at a seated position. Now, on which side of the JVP neck do you look at it? You look at it on the right side because it reflects the right atrial activity. Sometimes the JVP is very marked on the left side, and that is due to a persistent left SVC. And this is important for our cardiac surgeons and cardiac anesthetists because a left-sided SVC causes problems when they go to cannulate. We will skip all this and I will come to Cannon waves. I have only 5 minutes left and we have not even come to auscultation. The Cannon waves. What are Cannon waves? These are giant waves seen in the neck. And there are 3 causes. I don't know whether this will work. It's working. Now watch the video. You can see the external jugular and you can see that between the 2 heads of the sternocleidomastoid, occasionally a giant wave comes. Can you see that? Yes. Now, what is the differential diagnosis of these giant waves? It is due to the atrium contracting against a closed tricuspid valve. The atrium is contracting against a closed tricuspid valve. And when does this happen? When there is atrioventricular dissociation. When does atrioventricular dissociation occur? When the atrium is contracting at its own rate and the ventricle is contracting at its own rate. What is the classical case? Complete heart block. Ventricle is fired. How do you know? Complete heart block. Now let us say the patient is having a VT. The ventricle is beating on its own. Atrium is beating at a lower rate. Again, there is ventricular AV dissociation. Say you have gone and put in a pacemaker onto the right ventricle. Now the ventricle is beating on its own, the atrium is beating on its own, independent of each other. And therefore you find, if these Cannon waves are occurring with a tachycardia, the diagnosis is a VT. If these Cannon waves are occurring with a bradycardia, the diagnosis is a complete heart block. If the common Cannon waves are occurring with normocardia, very likely you have gone in and put in a right ventricular pacemaker, or it can be, of course, an accelerated idioventricular. So we will skip all this and I can't talk of pulses and anything, but then most of you would like to listen to some thing on physical science lectures go on for about ages, you know. Heart sounds, murmurs. 3 minutes more. So murmurs, how do you identify these murmurs? Always see where it is best heard. And systolic murmurs are best heard at 3 sites. At the base of the heart, which is the outflow tract, in between at the left lateral sternal edge, and then at the apex. And why do we say site best heard? Because the murmur must originate from the structure immediately below. Now let us suppose that the murmur is heard here at the apex. Now it must originate from the structures at the apex. Therefore it must be mitral origin, tricuspid origin, or the apical part of the septum. You will not come to this and say it is some other structure. Now again, if you come here and you find that the murmur is louder at the base of the heart, it must be at the outflow tract, aortic valve, pulmonary valve, or the superior part of the interventricular septum, or supravalvular, subvalvular lesions. In between, it is most likely from the interventricular septum because there are no valves at that point. So that is why we emphasize that when you analyze systolic murmurs, see where it is best heard. And when you look, and remember, it is always best heard over the trill. Some people say the trill is somewhere else and the murmur is best heard somewhere else. It cannot be. Your murmur is always louder on the trill. And therefore, this indicates to you the origin of the differential diagnosis becomes easy. I have no time to go over this. And remember, the aortic valves can be heard, aortic lesions can be heard anywhere from the apex to the aortic area. And therefore, now we don't talk of an aortic area, we talk of an aortic sash area, a band only systolic murmurs radiate. Remember that. When you come to diastolic murmurs, it is simpler. Either you hear it at the left lateral sternal edge, or you hear it at the apex. If it's at the apex, it is mitral or tricuspid. If it's at the left lateral sternal edge, then it is from the outflow tracts. So at the left lateral, and these diastolic murmurs, I may have a slide.
So you
all
can have,
diastolic murmurs at the apex are mid-diastolic. All diastolic murmurs at the apex are mid-diastolic. There is no exception to the rule. All diastolic murmurs at the left lateral sternal edge are early diastolic. Again, there is no exception to the rule. So the early diastolic murmurs are easy, lap-tap, lap-tap, lap-ta-ta, 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 the blowing murmurs. Whereas the diastolic murmurs, mid-diastolic murmurs are complex because the pre-systolic accentuations and the opening snaps are coming in, so that you have the rup-ta-ta, rup-ta-ta, rup, where the pre-systolic accentuation comes and then the mid-diastolic murmur comes through.
So you can have another 5 minutes.
Oh, thank you very much. And the causes of a mid-diastolic murmur can be mitral stenosis, very important, but also flow murmur across this mitral valve. Now, if you have a VSD, where is the blood flowing? The blood is flowing from the left ventricle into the right ventricle. From where is this blood going? From the right ventricle into the lung. Lung back into the left atrium. Which chamber is now full of blood? The left atrium. This blood from the left atrium flows across the mitral valve into the left ventricle, and therefore there is a flow murmur at the mitral valve. Again, the persistent ductus arteriosus, mitral regurgitation. Mitral regurgitation is a systolic murmur, but it can give rise to a mid-diastolic murmur because the left atrium is now full of blood, and this blood is coming through the mitral valve into the left ventricle, and therefore you can have a mid-diastolic murmur. You have the Austin Flint due to the aortic regurgitation, the Carey-Coombs where the multi valve is thickened, and thyrotoxicosis. This is important for clinicians because mid-diastolic murmurs are generally not infrequently heard, and when you find this, you must have a diagnosis of what is going on. Causes of a mid-diastolic murmur can be at the mitral valve, it can be also at the tricuspid valve. And at the tricuspid valve, if this is on the mitral stenosis, there it is tricuspid stenosis. And what causes a flow murmur across the tricuspid valve? When the right atrium is full of blood, and this happens in an ASD because the blood from the left atrium flows into the right atrium, and the right atrium is full of blood, and therefore you find that there is a flow murmur across the tricuspid valve. Now, this aortic, the diastolic murmurs, early diastolic murmurs are best heard at the left lateral sternal edge. Left lateral sternal edge, and that is aortic regurgitation. But there is an aortic regurgitation murmur which is best heard on the right sternal edge, and that is in dissection of the aorta, where the blood stream is such that it is directed in a direct opposite to the normal, and if you auscultate the left lateral sternal, and if you suspect dissection of the aorta, always auscultate the right lateral sternal edge for the early diastolic murmur, because in that case, that means the aortic root is getting affected, and these are patients with dissection who are at risk of arrest. Now, the approach to heart murmurs by description, systolic or diastolic. Now, if you find that the first heart sound and the second heart sound are heard, like in this first panel here, lub, dub, and then the crescendo is there. Now, if the patient is crescendo, decrescendo, first and the second heart sounds are heard. Lub, stub, lub, stub, lub, stub. The sh is the systolic murmur, first and the second heart sounds are heard. Now, if it is a pan-systolic murmur, like in the second panel, the first and the second heart sounds are obliterated. First and the second heart sounds are not heard. You have what is called early diastolic or the decrescendo murmur. Duck, duck. First heart sound not heard, second heart sound heard. Or you hear lubsh, lubsh. Again, the first heart sound is here in the crescendo murmurs. So, depending on whether you hear the first heart sound, depending on whether you hear the second heart sound, and how the murmur behaves within the first and the second heart sound gap, indicates to you whether you are dealing with a whole systolic murmur, mid-systolic murmur, ejection systolic murmur, etc. Sometimes you hear continuous murmurs, 30 seconds more. Continuous murmurs, persistent ductus arteriosus. Now, some people wonder how can I differentiate this from the aortic regurgitation and aortic stenosis, because that is also. When you listen, your ear tells you that the continuous murmur goes in one direction, whereas the ASAR is to and fro. And the ear tells you it may be that the blood is flowing in directions opposite. And that is the differential diagnosis. One small thing, when you hear these continuous murmurs, the persistent ductus arteriosus is best heard in the second intercostal space, but next best heard in the first intercostal space. Whereas, if you have an AP window, or you have a rupture of the sinus of Valsalva, then these murmurs are not heard in the second best in the first, but in the third or the fourth intercostal spaces. So with that, chairpersons,
You have 4 minutes.
Another 4 minutes.
Yeah.
Unfortunately, I have come to the end of the slides also. Because I skipped most of the slides. Yes. Now, the maneuvers. Inspiration. More blood is coming through. Don't remember the entire thing. Just remember only a small thing. Inspiration. Murmur is increases, right-sided murmurs are increased. There is a note there saying pulmonary ejection sound may disappear. Why does it disappear? It disappears because when you take a deep breath in, the lung fills up and the softer heart sounds are filtered off. And therefore, sometimes these right-sided pulmonary murmurs become less with this inspiration because of the bloating of the lung. When you exercise, what happens? All stenotic murmurs increase. Aortic stenosis, pulmonary stenosis, mitral stenosis, tricuspid stenosis, all these murmurs increase. And the common VMRs, VSTs, AR, which are also dependent on flow, increase. But remember that it's the stenotic murmurs that increase with exercise. When you stand, what happens? When you stand, your blood pools down in your lower limbs and the venous return is reduced. When the venous reduced is reduced, the left ventricle becomes small, and therefore the murmur increases in Hocum, because as the left ventricle becomes smaller, the outflow tracts also become smaller and it can easily obstruct. And remember, Hocum and mitral valve products behave in the same way, and with standing the murmurs change in this manner. When you squat, as this happens in pediatric cases, squatting, you squat and what happens? Two things happen when you squat. Your veins get compressed and therefore the venous return increases. Your arteries get compressed and therefore the peripheral resistance goes up. I'm simplifying the pathophysiology very much. And when you squat, the venous return increases and the afterload increases, and because of this, the patients with Fallot's syndrome, Fallot's tetralogy, when they get the cyanotic attacks or the hypercyanotic attacks, they squat. And when they squat, the venous return increases and the right ventricle gets distended and more blood is supplied to the lung. Whereas when you squat, there is arterial compression and the pressure in the right side, left side goes up, and therefore the shunting from the right to left is reduced. And therefore these cyanotic attacks tend to disappear. The hand grip, again the same as in the squatting, and which you can remember. Sometimes this coronary AV fistulas, but we have no time to go into this. There is a benign systolic murmur of young adults. Innocent supraclavicular systolic murmur can be loud enough to cause a thrill which gets transmitted to the base of the heart. I must give a small explanation on this term, base of the heart. Now, if you take a flask, the base of the heart is at the bottom, but in the heart it is the opposite. The base of the heart is at the top, and the apex is at the bottom. So when we say base of the heart, don't think of the bottom of the heart. Some students sometimes think of that. When we say base of the heart, anatomically we are talking about the top of the heart. And we auscultate with the patient seated in the relaxed position with arms on the lap, and you place the belt in the supraclavicular fossa and hyperextend the thing, and the innocent supraclavicular murmur then diminishes or disappears. And then this is the physical sign that you can detect, use to indicate that it is a benign systolic murmur. I think I will stop there. Thank you very much.
Thank you very much, sir, for this very, very interesting lecture, reminding us the very basics of clinical cardiology. And this, I think in the interventional era, we forget most of these very basic things, but it's utmost important. Thank you. Thank you, sir.
Thank you very much, sir, and thank you to the chairpersons. Moving on, we have an important event to mark. That is the issue of the Sri Lanka College, issuance of the Sri Lanka College of Cardiology Journal. We are issuing the first and second issues together as a combined issue on this occasion. So the January and June 2022 Volume 5, Issue 1 and 2 of the Sri Lanka Journal of Cardiology. We would like to present it to some of our guest speakers today. And for this occasion, may I cordially invite the Editor-in-Chief of the Sri Lanka Journal of Cardiology, Dr. Ruwan Ekanayake, who has been a pillar of strength since the journal was first introduced in 2017. Sir, thank you for continuously supporting the journal and being its Editor-in-Chief over the years. May I invite some of our guest speakers who are present here? Right, okay. Professor Raman Puri. Dr. Ruwan Ekanayake will now be presenting the journal. Professor Raman Puri.